Hi, I'm Dr. Janet Pope at Room Now. I'm thinking about a roundup of some of the learnings from this great ACR 2020 convergence. So, I'd like to tell you about learning from a cohort. So, I'm going to talk about the early rheumatoid arthritis incident cohort or the CATCH cohort from Canada. So, this has over 3,000 patients. And the first thing I'd like to talk about is very applicable to us doing telemedicine during the COVID era. So abstract number 483 compared the CDI, that would be the traditional clinical disease activity index, which, as you know, is MD global, patient global, swollen joint count, tender joint count. And it compared with a patient CDI that obviously would be the patients doing their own tender and swollen joints and giving their global assessment. And what it found was that there was really high agreement at both ends. The agreement or kappa was about zero point 0.7, which is pretty good at both ends. So if the patient says, my RA is doing really well and I've actually gone through this and my tender and swollen joint counts are low, you should agree with them. And at the other end, if they say my tender and swollen joint count is high, my CDI is really high, you should probably agree with them as well, because agreement in the middle was a little bit more scattered, but the ends were quite in agreement. So I think that's important when we're doing telemedicine. The next is, what about regional and widespread pain? So we've published in the CATCH cohort before that incident fibromyalgia is about 5 to 10 fold higher in the first 2 years of getting rheumatoid arthritis. What abstract 187 looked at was, what about regional pain and widespread pain, and how does it change in the first year? So, first of all, pain is common when you have new rheumatoid arthritis. One third of patients at the beginning of the study had regional pain, and fortunately, it went down to a quarter at the end of a year. Whereas widespread pain was 1 in 5 at the beginning of the study. And at 1 year, it also cut in half to about 1 in 10. So some of these patients will have residual pain, and it does affect their global assessment of what's going on. Then to look further, what about remission? So abstract 1715 looked at remission. So I'll give you the good news and then not the good news. The good news is 55% of the patients followed, over 3,000 patients, had an SDI remission ever. So the good news is more than half. The bad news is 45% never achieved remission in early RA that are being followed over time. But there's even more bad news. Of the 55% of patients who were in SDI remission, over the next 2 years, half won't stay in remission. So we need predictors of who will get into remission and who won't, but also who will sustain remission. And maybe it's related, maybe it's not, to medication beliefs. So, abstract number 151 said half the patients don't believe meds are necessary for their RA. That doesn't mean they're taking the meds. They might think they're not necessary long term because they have it, what they think of as an acute problem of pain, but they do have a chronic disease. The final lesson learned from this cohort is that if you have poor function reported as your hack, you have a far higher chance of dying. So abstract 1736 looked at mortality related to hack. And it's not just the comorbidities of coming in with a high hack, because it was predictive at 1 year for mortality and it was less predictive at baseline. So what does that mean? That if you can't improve function from your RA deficits over that first year, you have a poor predictor of survival in the long term. So I think we can learn an awful lot from cohort studies. These are sometimes difficult to fund because the questions can vary depending on what we're finding, but these are all important lessons learned. So take care and follow us at Room Now. Thank you.